Made-up case, kind of.
All right.
All right, guys. For those of you who haven't met yet, my name's Ash. I'm one of the fourth-year residents. Um, the whole point of this lecture is kind of go over a topic that we all probably know pretty well, and you learn it as an intern. But let's say you're out by yourself in the future in a weird hospital, and you have no backup. What other steps you can take that aren't discussed as much in this specific case? So we're gonna start with a little story. So just imagine you're a young, fresh, new doctor working in an overnight hospital by yourself, maybe somewhere in Canada, um, maybe really far north in Canada where you have nobody around you, and all of a sudden you get this little old lady come in, really bad headache. She's vomiting. She says she can't see at all. She's not able to even give you any more history other than that. Fortunately, you know exactly how to do a really good exam. You look at her eye, you see one eye is super red, mid-dilated pupil that's barely reactive, cloudy cornea. You even know how to check the depth of her anterior chamber, and you place a light on one side of her eye, and you see that it casts a shadow on the other side. You already know that she has a shallow anterior chamber. You check her pressure, and it's 66. Ignore the bad photoshopping. I couldn't find a high pressure um, so, being you know immediately it's an acute glaucoma. Perfect. You move on, you get on the phone, you call your ophthalmologist. It's a really angry dude. It's like 4 a.m. and he's like, "Why are you calling me for this?" But he gives you some recs. Being in Northern Canada, you have terrible phone reception. So he says maybe some Timolol, maybe Diamox. You don't get any doses, you don't get any repeats, nothing. And then he says because of the blizzard that's coming in, he won't be there for another 6 to 8 hours, so you're on your own. So at this point, if you're not fixing this patient's pressure, you're going to have to kiss your ash goodbye. Luckily, you went to county, and you know a thing or two about acute angle closure glaucoma. You know that it's an optic neuropathy that's usually associated with elevated IOP, and the main treatment is to get that pressure down. It has a classic, typical set of symptoms, which I'm not going to say every single one, and quite a few physical exam findings that you look for. As you remember back in med school, basically it's caused by anatomic variations causing a pupillary block when your eye gets dilated. The ciliary body and the lens kind of are at their maximal thickness. When you have a mid-dilated pupil, it protrudes forward, narrowing that angle further and blocking aqueous outflow. But there are other causes. Anything that blocks this outflow can actually cause an acute glaucoma. Ophthalmologists call it secondary glaucoma. Typically post-inflammatory changes, neovascular changes in our diabetics and hypertensives. If they've had any significant trauma with a hyphema. A lot of medications can provoke it, namely mydriatics and pathomimetics. Interestingly, Topamax tends to be the most common medication that's not related to pupillary dilation that can cause it. Mass effect, like intraocular tumors can cause it, as well as if they inject any kind of oil or whatever from a ophthalmology procedure. And lens changes, like acute dislocations or malignant cataracts. But in the end of the day, you end up getting this elevated intraocular pressure, which causes potentially irreversible optic nerve damage. And in a lot of ways, it's very similar to a herniating brain, right? You got to reduce that pressure before you get any kind of permanent damage. And a lot of our basic treatment is going to be similar. You're going to elevate the head to bed, treat their pain, their vomiting. Blood pressure control is a little bit less important since a lot of the medications we're going to give are going to lower their blood pressure. Hyperventilation isn't typical because they're not getting intubated. But fortunately, we have a whole host of medications that you can provide. And an easy way I always find to remember is just my ABCs. A is your alpha-2 agonists. Typically, we'll use aproclonidine. You can remember there's two main functions it has, decreasing aqueous production and increasing outflow because it's alpha-2. Depiprazole is an interesting one I just learned about that basically helps reverse any glaucoma secondary to mydriatics that may have been given to patients. So just keep that in mind if maybe you're doing a dilated exam and all of a sudden the patient can't see anymore and you kind of did it, you can give depiprazole. B is your beta blockers. You can remember that these block aqueous production. Timolol is typically what we use. Be careful in certain patient populations. It's not necessarily a contraindication, but it's just something you want to be wary of if they have severe reactive airway disease, heart failure, or if it was caused by maybe like cocaine that they had just used earlier. C is your cholinergics. These typically work by causing some degree of meiosis and increasing the outflow. It's important to remember, luckily it's ABC, so remember this comes after the other medications because when you have increased pressures, you're going to have some degree of ciliary spasm and it might not work right away. Typically, you're going to want to drop the pressure a little bit before applying this. D is a whole host of different diuretics you can provide. Acetazolamide tends to be our first go-to. Dorzolamide is a topical carbonic anhydrase inhibitor that we often use. And then in really refractory cases, you can consider mannitol. And all these medications, I guess in the carbonic anhydrase inhibitors, be careful in patients with sickle cell as you can provoke an attack, a crisis. And you want to be careful if their blood pressure at baseline is low because you can drop it further. E is probably the most important, the emergent ophtho consult, because ultimately a lot of these patients need some sort of operative management. And they may recommend some other medications that don't tend to work too quickly, like prednisolone and hypertonic saline. They tend to help with the corneal edema that lingers around after you've dropped their pressure, but that's something that they'll recommend for you. And then prostaglandin F2s, they often recommend we start these, but I've seen a whole host of data saying that their effect is very unreliable, and oftentimes you get a paradoxical increase. But you know, if your ophthalmologist recommends it, it's just something that you should probably give. So going back to our case, Brett Barrow already consulted ophthalmology. He knew already to give some Diamox. He gave some Timolol, aproclonidine, and pilocarpine. About an hour later, he may have redosed a couple of these things, and the pressure was still high. So he went next to his mannitol, and the patient's pressure, despite all that, is still greater than 50. She still can't see, and it's still going to be another 4 or 5 hours till he gets that ophthalmology consult. So what other options does he have? Fortunately, in China and Japan, they have this all the time. They have a lot of rural hospitals, and they actually have experimented with a lot of different techniques to lowering pressure. One method is lidocaine, actually, which I thought was very, very interesting. It's actually in a lot of the ophthalmology journals. So here's one big article. I guess it's not that big article. There were only 5 patients, but here's one of the interesting articles I found. They took all these patients with their first attack. They all received maximum topical therapy as dictated by their ophthalmology consultants. And despite that, still had pressures greater than 45 at 4 hours post-treatment. Then they got a single bolus of lidocaine. And interestingly, you can see a pretty dramatic decrease in their pressures. Not only that, they did have complete resolution of their pain, their nausea, their vomiting, and return of their visual acuity. And all of these patients were able to have their surgical management delayed by at least 3 days. And on top of it, I know you're giving lidocaine, you might be worried about arrhythmias. None of them had any complications. Granted, this was only a 5-patient study. Take it for what it's worth. There are some other more aggressive techniques that might cause a little bit more controversy. But again, these are all well described in the ophthalmology literature. The typical one that most ophthalmologists in their clinic use until they can get their patients to any sort of definitive surgical management is actually called corneal indentation. It's done by taking a Q-tip and applying it to the cornea for about 30 seconds, releasing it for 30 seconds, and repeating this whole process for about 10 minutes. The idea, it's not fully well known to understand how it works, but the idea is that it pushes the aqueous to the periphery and lets some of it drain out through the trabecular meshwork. Again, they typically do it if there's going to be any sort of delay before operative management. And one study I found in the ophtho literature showed that there was a mean reduction by about 21 millimeters of mercury, which was kind of interesting. A lot of these patients with glaucoma also have prior history of glaucoma, especially congenital glaucomas, and they may have valves in place that help drain. So oftentimes these valves, they malfunction like every other valve. Think of it almost like a VP shunt. If this valve you suspect is maybe obstructed, one very well-known method is ocular massage. And again, you want to be careful that you're not popping their eyeball, but it seems counterintuitive that these patients have elevated pressures, but they suspect that the ocular massage helps open up that valve and push the fluid out. And then the last one, probably my favorite one, is anterior chamber paracentesis. This is actually this is used to be done much more frequently back when ophthalmologists didn't have lasers for their surgeries and they had to prep patients and actually do it with blades and whatnot. But the whole idea of this is that you take a 26 gauge or 36 gauge needle, place it in the anterior chamber, and move about half a cc of aqueous, and it has I'll show you some research that's been done on it actually pretty recently. But like with every procedure, there are certain indications and certain complications with it. Typically, they recommend this on patients who have failed maximal treatment, so you're not going to go first line with this. And if there's going to be any significant delay to definitive care, namely 4 to 6 hours, patient has had full treatment, still delayed, there's not going to be any type of laser iridotomy done in any reasonable amount of time, and this can be considered. And again, there's a whole host of complications. You can pretty much damage any of the surrounding structures, the lens, the ciliary body. You can actually provoke a malignant glaucoma. If you think about pulling out too much fluid, you might actually cause a negative pressure effect and bring that lens further forward. Intraocular hemorrhage and endophthalmitis.
We're convinced.
Yes, yes. So here's a pretty good study that I found on it. These patients, this was all done by ophthalmologists. All of these patients received maximal topical therapy and IV meds. All of them still had persistent pressures greater than 50 millimeters of mercury about an hour after treatment. So they ended up doing some anterior chamber paracentesis, and they had almost immediate reductions in pressures, as you would expect. Fortunately, none of them had any significant complications, and 6 of them actually went a week without even having to require any further treatment or even laser iridotomy for their glaucoma. And I know, yeah.
Pre-treat with some topical antibiotics?
Yeah, so they typically are given before and after some Ocuflox prior to the procedure. I know this sounds like it's great because ophthalmologists did it and there were no complications, but I found a study from Romania, where they're allowed to do a little bit more aggressive stuff. They had 24 patients, all in the ER, all of these done by ER patients. All of them were given, again, maximal topical therapy, still had elevated pressures. They did the same exact thing, no complications in any of them, and again, 8 of them actually didn't require iridotomy. So it's almost like we did it better than the ophthalmologist did. You can think about that. And then this last one. This one was interesting because they incorporated it into their first-line treatment. So instead of going with the indication of like delaying it, they did it almost immediately. This, I forgot where this one's from. I think it might be China, actually. But this was done by ophthalmologists, not by ER doctors. And none of these patients ended up needing surgery within a month after the actual treatments. I thought that was kind of interesting. And all of this stuff kind of made me want to talk to our ophthalmologist about it, see what they thought. And I don't know how many of you know who Stavros is. I know the third years probably know. I asked him what his thoughts were on this being like done, and he said there's quite a lot of data on it, that they used to do it in the past. Obviously, if you have ophthalmology available, you're not going to do it. That's kind of ridiculous. But if you're kind of in the scenario that I maybe described earlier, where there's going to be a delay, and you've done maximal therapy, and you know that the patient's pressure isn't going to drop, you don't have a whole lot to lose. He did recommend starting with corneal indentation because it's a little bit safer. But he did give it his seal of approval. So that was, I thought that was pretty nice. And he did go over with me their sort of algorithm for their treatments of acute glaucoma. First thing, obviously, is we're going to call ophthalmology. Second thing you're going to do is probably give everything all up at front. You're going to give them Diamox, PO, or IV, depending on whether or not they can tolerate PO. You're going to give a dose of timolol, and you can repeat that about 1 hour after the first dose. Aproclonidine, same kind of dosing regimen. I know I said pilocarpine you're going to give after those. He recommends giving it at the beginning and then giving another dose 15 minutes later. His thought is, it's probably not going to work, but you can at least give it. It's not going to harm them either. If after giving all these treatments about an hour, you're going to be checking pressures Q15 to 30 minutes. If the pressure is still elevated after an hour, at that point you can give one of your osmotic agents. I've never seen glycerin be given, but he did say that's an option for patients who are tolerating PO. Mannitol, I feel like, is probably the way to go in this situation if their blood pressure can handle it. And then if their pressures are still elevated after about 4 hours despite all this treatment, and you don't see any sight of ophthalmology coming anytime soon, you can consider corneal indentation or paracentesis. Ultimately, these patients are likely going to need laser iridotomy for their treatment. I'll leave that up for a second. Any questions on anything? Yeah.
Two things. If they have neovascular glaucoma with diabetes, they use methazolone because it's not.
There you go. I didn't know that.
They're gonna call everything to you in brand names. Zalatan, Costab, Alpine.
Right, they will.
They first said it's made in Zalatan. I was just curious. It's just like it felt totally screwed. Trying to figure everything out.
He's right. They do like their brand names, and some of them are combination meds, just to keep that in mind. But I figured I'd stick with this just so you had an idea of what you're getting. Taco.
Sorry, go ahead.
Well, I just didn't hear. What did he say not to use with diabetes?
Methyl
Renal failure, they want you to use methazolone.
methyl-zolamide. Yeah.
Just another thing is that just be sure to put them on the monitor while you're doing this.
Yes.
They can get instant absorption. But also, just whenever you're giving drops, always just include the medial punctate so that it actually stays in the eye and it actually decreases how much systemic absorption you get. So, yeah, hold your finger over just like this part and then drop it in so it'll stay in the eye.
I like that. Anything else? Questions? Yeah.
When I was a resident, the vast majority of patients I actually saw before.
Yeah. Yeah, I think I've only seen it in North also.
Well, it's really important because they come into triage with a chief complaint of headache, and in order to facilitate their workup, they look really bad, so they're given some narcotics and a CT scan requisition, and then they come back from CT perhaps with impaired, we should have been on it earlier.
Right.
That just so, I always say with headache, before you send them to CT, just look at them because you'll never miss it. Just look at their face. You'll see one eye is one copy of their head. It does. Every year we get an M&M like that. And you're like, what do you mean glaucoma is on the differential for a headache? What idiot would miss that? And I'm like, me. Like 10 times, right?
Any other questions? Yeah.
Oh, the shits tonometer.
Well,
I'll show you later. It's the shits. We used to measure eye pressures. We had to learn, along with manual nasal packing, we had to learn how to measure intraocular pressure using an old device. Put on Google, called the Schiot's tonometer, which was basically like doing a circus act on someone's eyeball. So they'd be lying down and you'd be balancing like like an acrobat act on their eye. The thing would go up to here and you'd be putting weights up and down.
I don't know how to spell it.
Seems
right.
And that's how we used to measure
Shit,
intraocular pressure.
maybe?
before you
S-H-I-T?
Just put the whole thing on and get the number in 2 seconds. So be happy here now.
How do you spell that? It's not
There,
finding
Schiot's.
Schiot's tonometer. Oh yeah.
S-S-S-C-H-O-T.
oh, they
Yeah.
can't see it.
Hold on, we'll move it over.
It's weird as hell.
What is this doing?
Yeah, Tiger Medical. There it is.
Yeah. I can't.
Scroll down.
There it is.
Oh, there it is.
There it is. So you would balance. This is it. Balance. The patient's lying down. You put some proparacaine, and you put this on their eyeball, and then this whole thing is this eye is sticking up over their thing, and then you have to put the weights on here until you find the balance like a scale. It also can be used as a wine opener too. I think.